So, hey, everybody. We're going to get started. So, it's funny that I'm introducing Ryan because I'm not biomedical engineering. And yet I was asked to do it. And I was glad to do it. But I may not be the perfect introducer because I don't know all your work as well as some people. But I did want to mention, just for one thing, that I just got back from the Collegiate Inventors Competition in Washington, D.C., where there's an undergraduate group and a graduate group. The undergraduate groups, it's like from 6 schools, all biomedical engineering innovations. And a lot also on the graduate side. But as I was listening as a judge to these presentations, I couldn't help but think, like, wow, we need more people from Dartmouth applying to this competition because it's a $10,000 prize, a bunch of other benefits, and I think we could clean up, personally. So we just have to remember next year. Put it on your radars. It's a good thing to do. And we have competed in the past and done okay. So, especially biomedical. So anyway, back to Ryan, who's in the biomedical area. So Ryan gave me his bio, but Ryan is an associate professor and biomedical program area lead here at Thayer. He studied engineering science and mechanics and biomedical engineering at Penn State University and at Dartmouth. He received his BS and MS from Penn State in 1999 and 2001, his PhD from Dartmouth in 2006. Keith?
Alex Hartov.
Alex Hartov.
Mm-hmm.
Okay. Excellent. And then he went to what's now Dartmouth Hitchcock as a postdoc for 2 years. Right. Honed his skills and then came back to teach here. All right. Mm-hmm. A little bit before I got here, actually. So anyway, his focus is on medical technologies at the interface between surgery and engineering to enable, this is actually a good sentence, to enable clinicians, to enable clinicians to better detect, diagnose, stage, treat, and monitor patients with a variety of pathologies. So he's developing novel surgical navigation frameworks. And what really excites me is that he's very interested in getting this out to benefit society. And he's doing that from an entrepreneurial point of view by starting startups and taking the best students you can get a hold of and perhaps others. And some that come through the PhD innovation program as well. And hopefully I hear that maybe in another year or two there will be actually impacting human lives, touching human lives. So looking forward to that. So he's the CEO of, founder and CEO of Rytech. What an interesting name. Where did you get that idea? Rytech Medical Inc. And has, of course, been supported a lot by SBR and STTR awards. And co-founded Multivariate Systems, Synchro Health, and AssureTech Surgical. So it's my pleasure to introduce you, Ryan.
Thank you.
Looking forward to your talk.
Thank you very much. Thank you very much. Thank you all for coming today. Thank you, Eric, for the introduction. Happy to be presenting today's Jones seminar. I've had the opportunity to present a couple of Jones seminars in the past, and I've started out with this image in the past. And I've usually asked the question to try to kind of get folks involved. And so if anyone came to one of my talks before, does anyone remember what this is? What this represents? And if not, does someone have a guess what this might be? Hailstorm. A large hailstorm, okay. Other guesses? Yeah, that's right? So this is trepidation. This is the first archaeological evidence of a surgical procedure that was performed. And so, someone back in the Stone Age had bad headaches, and they went to their local Stone Age doctor, and they took some some arrowheads, and they kind of carved around their skull, took a piece off, and it kind of alleviated the pressure. And the really interesting thing here is that the edges of all of these holes they put in have healed slightly. So the person lived with this. And so these were survived surgeries that people underwent. And so one of the first surgeries that were performed. So another bit of history. Does anyone know what this is? Yes? Yes? So what is this? So this is a wrist x-ray. That's right. And so this wrist x-ray was done here at Dartmouth. It's one of the first diagnostic x-rays that was performed in the United States. And so this was a kid who broke his wrist, and there was a Dartmouth physician and a Dartmouth College physicist built this x-ray machine, and they were able to image this wrist as a diagnostic. And so it's one of the first diagnostic x-rays, right? And so Dartmouth's had this rich history of medical imaging. And so what I'm going to talk a lot about today is combining medical imaging with surgery. And it's come a long way since those stone-based trepanation type of procedures and these early diagnostic x-rays that were performed at Dartmouth here. And so when we think about, I think about at least combining medical imaging, I can relate it also to kind of mapping the world. And so we have a map, right? And so that's how we might navigate in the world. And so what medical imaging really provided was, okay, now instead of going in and saying, okay, this person has a headache, let's put holes in their head. Let me see what's going on. And then maybe we can figure out where to appropriately put that hole to alleviate the pressure, right? And so we can map the world, we can map the body. And so we have these nice MR images that show a nice glioblastoma, and it allows us, the surgeon, to know kind of where they might want to go and treat this patient. And so medical imaging basically was a tool to improve surgery, right? And so move forward right now we have apps, and now we don't just have a map of the world, but it tells us where we're at in that map, right? So we're navigating within the map, right? And so surgery has also taken that pathway as well, right? So now what we can do, this is an example of an MRI that we see in 3 different views of the patient. We have a 3D view of the model of the patient up in the top corner. And there's these cross hatches that they're kind of a little tough to see, but they're coming across through these different planes here. And those cross hatches are indicative of where an instrument is in space. And so now, just like we were mapping where our car is in that map, the surgeons now can take an instrument and they know where their instrument is within the map of the patient. And so image registration, so we are able to map our MR images to our patient. We have instrument tracking, so we're tracking where that instrument is in space, and it leads to improved neurosurgery, so we're providing location. And so the general principles for image-guided surgery, you have a number of components. So you have an appropriate patient imaging data set, right? So that's our MR or our CT, so that's our map that we have, right? Then we have to relate our map to our patient, right? So we get our map over here, and we have our patient. So we have our patient sitting in the OR, and we have to know how to relate this map to this patient. And so there's little fiducials we can put on a patient, these little marks that we can probe with a trackable instrument. And by looking at those points, we can map. And so we have a mapping function here that basically says points in the MRI. We have this mapping function, this transformation that takes us to points in the patient space. And so when we think about surgical navigation and we're using imaging, we're trying to relate those images to where the surgeon is actually interacting with the patient. And so this is just a mapping function that allows us to do that. The other component we need is trackable surgical instruments, right? So our cars have GPSs, or we can track where our phone is in the GPS. We need some type of thing on our instrument. So we usually use an optical or an electromagnetic tracking approach to map where our instrument is. And then the final thing we need to do is actually provide that information back to the surgeon. And so in this particular case, what we have over here, it's a triplanar view. So we see 3 different views through the head. And just like our app on our map, we see where we're moving within the app. And so This has worked pretty well for neurosurgery, but there's some limitations, right? And so you think about this, this is some work that Xiaoyao Fan and Keith Paulson's group and Alex Hartov was involved with this work. If you start out with a map, your map of your brain, and then you decide you want to go and actually cure this patient. So we're going to go and take that glioblastoma out. And what typically happens is we have to do a craniotomy, so we pull a little bit of that bone away. And when we pull that bone away, the tissue moves on us a little bit, right? And so when the tissue moves, that means our map is not working anymore, right? It's not valid. And so this is a challenge with soft tissue. With bony tissue, so that cranial vault there, that's staying fixed in place. And so that's why this has worked pretty well for neurosurgical applications or orthopedic applications where you have rigid bone that stays in place, right? Once you start getting soft tissue and you start manipulating it surgically, then we get soft tissue motion, deformation, and our map is no longer valid. And so, for instance, we had this earlier, right? And I put this up pretty quickly, right? But if we look a little closer, we could see if we tried to come to Thayer and we were going to come down Engineering Drive and park in Cummings, we'd be pretty disappointed because that parking lot is no longer there, right? And so our map is out of date. And so the idea would be is we'd want to update that map in some way while we're performing the surgery. So that's what we're looking to do is say, okay, can we look at soft tissue applications, not just cranial or orthopedic procedures where you have rigid bone, but really start looking at soft tissue and how can we kind of bring some of these surgical guidance technologies into those other spaces to provide benefit to the surgeons and clinical outcomes. And so when we think about approaches you might take for more soft tissue applications, right? So you could imagine if you've deformed the tissue in some way, right? We could just say, okay, let's take another intraoperative image. Okay, so we've deformed it. We'll get another image and we have a new updated map. And so now we can trust that map. So that's one approach one could take. Another approach would be say, okay, let's make some measurements of the tissue that moved and then let's use some deformation model and let's update our initial map to make it match what we're actually seeing in the surgical space. And then the third one would be some mixed approach there where you might have some intraoperative imaging, some deformation modeling, you might bring them together. And so this has had a lot of success in rigid bony applications, right? And so using preoperative imaging, it's become standard of care for some of these applications, and it's aided by these rigid bony structures. Soft tissue deformation in neurosurgical applications. So Keith Paulson's group has a long history of kind of looking at deformation modeling in the brain and seeing what happens when you remove part of that, right? And so one of the nice things about the cranium is that you have this rigid vault that's around the soft tissue. And so you can understand the boundary, you can define the boundary conditions a lot better. And the deformations are slightly smaller than you might see in other soft tissue applications in the body. So it's worked really well there. And then when we think about metrics of success, there's clinical metrics, right? So disease-free survival, negative surgical margins. We'll make sure we get all the cancer out if we're doing cancer surgery. Maintained quality of life. So, we can treat cancer by taking this huge lesion out, but you might have a really decreased quality of life because you removed a lot of functional tissue. And then we can look at technical metrics of success, which might be things like targeting accuracy, your registration accuracy between your preoperative images and your intraoperative space, the modeling accuracy if you're going to have a model there, or maybe the time, right? So we want to do this in real time so we can provide that intraoperative guidance, so real-time feedback. So this is what we're thinking about in terms of soft tissue. And the question that we ask is, can we develop similar technologies to provide navigation in the soft tissue space? And so today I'm going to talk mainly about work that I've been doing in the pharynx and larynx, so the oral cavity. This is work that I've been collaborating with Joe Pedafar for many years. He's a maxillofacial surgeon, does these procedures, and with any, I think, biomedical development, having really close collaborations with the clinic has really helped move the technology forward because we understand what's needed within the clinic and we're addressing, I guess, those real problems. And so, just kind of to set the stage, right? So, oral cavity cancers, are the fifth most common worldwide. There's about 60,000 new cases each year, 12,000 deaths. There's a rising incidence due to HPV infection. And in terms of anatomy, right? So when we're talking about the oral cavity, we have the nasopharynx, the oropharynx, hypopharynx, and the larynx. We have a bone down here is the mandible. We have the maxilla up here. This is the mouth opening, and here's the tongue. And so that's kind of the anatomy that we're working with. And you can imagine, right, I'm up here talking and speaking, right? And so my mouth's moving quite a bit. So there's lots of deformation there. Your tongue moves quite a bit. And to get access to the space surgically, we actually move that tissue a fair bit. And we'll look at how much we move it here as we go forward. And so the traditional surgical approaches for treating cancers of the neck and the oral cavity were twofold. Usually you had either a transcervical approach, which meant that you cut into the neck, you opened this up, really exposed everything, and then went in and took a tumor out. The other option was a transmandibular approach. And in this case, you actually bisected your mandible, so that bone right here in your jaw. You pulled it across, and then you opened up that whole space and went in there and were able to palpate and take the tumor out there. And so some benefits, right? So really good exposure. So, right, you open this up, the surgeon can see everything that they're working on. You could find where the vasculature is, where the nerves are, so you can really see all the critical structures prior to taking that tumor out. So, the surgeons want to be careful that they're not hitting some of those critical structures. And then the other thing is, it was open. Surgeons were operating with their hands. They could palpate. They could feel where the tumor was. The tumors are typically stiffer. They could push things away. And so you had a lot of advantages to this procedure. There are some drawbacks. So the operative time was quite long, right? So to do all of this other stuff just to get to the tumor takes a long time. You can imagine morbidity. So morbidity is kind of the damage after surgery. Huge recovery times associated with these very significant procedures, and then a very increased complications due to all the extra stuff you have to do just to get to the tumor. And I also should comment here before I go on. I'm not sure what the next slide looks because I don't have that presenter view, but there may be some slides here that show surgical scenes, blood, and things like that. And so just letting folks know. I think last time I gave a talk, a Jones seminar, someone made a comment that they would have liked to have been warned. So I am putting forth that warning. All right. So there's been a huge paradigm shift in how these procedures are undertaken to a minimally invasive approach. And so two primary approaches are used, and we'll talk about some technologies we've been developing for both of these. One is transoral laser microsurgery. And so what we do here is we take a tube called a laryngoscope, and we place that inside the patient's mouth in through their oral cavity. The surgeon then operates through a microscope, and a laser is shot through here to take out the tumor. There are other procedures performed through this tube as well, so they can put small little chopstick instruments down that tube and do biopsies and things like that. But it's through a tube that's placed in the mouth. The other approach is robotically. And so here what they do is we put a retractor in the mouth. We open up the mouth as wide as we can, and then these instruments are brought in. We have a stereo vision camera so the surgeon can see inside there. The surgeon sits away from the patient now, and then the instruments move and they perform the surgery robotically. And I guess one other thing to note is that typically in these oral procedures, surgeons are striving to get what's called a 3 to 5 millimeter margin maximum. So that means that when they take the tumor out, they want about 3 to 5 millimeters of benign tissue around that tumor as well. And that just leads to better outcomes for surgery. You don't have as many recurrences coming from that. So that's a number that you kind of strive for when we think about margin assessment. Okay, so approaches we're thinking about, okay, so now can we think about image-guided transoral surgery or image-guided transoral robotic surgery? And so we mentioned these three methods earlier: intraoperative imaging, updating a model, or some mixed approach there. So some of the challenges with implementing this in the transoral surgical space are So our intraoperative CT isn't always available. So we have a really nice operating room over at DH called the Center for Surgical Innovation. In this space, we have intraoperative CT, we have intraoperative MR, but this is a very high-tech, high-cost facility that isn't always available. So getting an intraoperative CT is not always available. Takes a long time to acquire if you're going to do that, not always compatible with other surgical instruments. There's significant imaging artifact associated with metal retractors. I'll show you some images of this soon, but you saw that tube we put in the mouth or the retractor to open, they're metal. And so we can't use it in MRI because it's not MR safe. And within a CT, we get a lot of artifacts, and I'll show you some of those artifacts in a minute. So really hard to say, okay, we're going to get an intraoperative image when the patient is in that deformed state, which is really what we want, right? We want them in that deformed state and be able to operate on that image, but it's challenging. And then also, as they're operating, if we really wanted to keep doing intraoperative imaging, we have to continuously get this frequent re-imaging, which is challenging. And so what our lab has been really focused on is looking at new tools that we can develop that can enable some image guidance in transoral surgery and transoral robotic surgery, and then thinking about how we could take those tools and integrate them in a framework that allows for this image-guided surgery. The two significant challenges, I'm just going to, it's soft tissue deformation. And so you can see here is just an example, cartoon-wise. Here might be the tongue, or a tumor in the tongue. As we put this in, we get this significant deformation that occurs. And so that's one thing we have to combat and think about. And then the other thing is these metal laryngoscopes. So all of these kind of streak lines here, all of this, this high white contrast here, those are artifacts. And it makes it really hard for a surgeon to kind of see the critical anatomy, so vasculature or the tumor that they're really interested in. So these are really big challenges for thinking about how do we implement image guidance in transoral surgery or transoral robotic surgery. And so, what we wanted to look at first is, how much deformation we actually get, how much deformation is there, and how do we assess that given the significant metal streak artifacts. So I had a student, Dennis Wu, who did some really great work. We developed this 3D printed laryngoscope. And so we modeled this directly off of the metal intraoperative scope that they currently use for these procedures. This is the tube that goes down the mouth. And so Dennis built this modeled it directly off of that. We took it into the OR and it bent a whole bunch, right? So it's a 3D printed, it's polymer, it's just not as strong as metal. But we put it in a patient, we saw that there was a lot of bending, that we had there. So we went back, he did some modeling, he recreated, made some design changes to this to make it a lot more robust. I will say one of the nice things in terms of collaborating with the clinicians, right, is we do get to build these things. And I say this all the time when I'm talking to people who want to come to Dartmouth, or what's great about Dartmouth is, like, in the biomedical space at least, we get to build things, we test them, they fail or surgeons break them, we go back, we iterate, and we get to the point where we have a functioning device. And so this is an example of that, which I thought was really great. And so we have this new laryngoscope. We also built this nice little worm gear that allows us to actually adjust this. And so what happens is the surgeon can place this inside the patient, can come up here and adjust the worm gear to change the angle. So this is oftentimes surgeons like to have some adjustability in some of their retraction. And then we built a frame here, and all of this had to be built out of plastic or polymer so we could get this in the CT or the MR without getting artifact, and it had to fit within the bore of the CT, so we had some geometric constraints as well. But at the end of the day, we had this really nice system that allows us to actually create or capture CT and MR images. And so here's just some examples. We had all this streak artifact that I was talking about up here, and with our laryngoscope, we see these really nice crisp CT images, no artifact there. MR, we get this really nice MR image, soft tissue contrast, that we could not get before with the metal retractors, right? And so this is something that was new, that we're able to actually see the deformation that a surgeon actually has been in the past. What they've done is they get that pre-op image, and they make some estimates about where things are going with that map, right? And so that's what they've done in the past. And now we're actually showing where the tissues are moving. And then the other thing is they look at endoscopically. So this is our polymer-based retractor and our metal retractor. And we have similar field of view. So this is what the surgeon actually looks down and what they're operating on. And so similar field of view there. So what did this allow us to do, right? So the preoperative image, here we have a standard neck CT. So patient goes in, they lay back, they get this CT, their mouth is closed, here's the tongue. They come into the OR and their neck is bent back, right? Even before the retractor is put in, they put their neck back so they get better access to it. And just that motion alone, we get significant deformation here. So the mouth is open, the tongue starts moving a little bit, the spine is bent, right? And so we have some deformation there. And now we put that retractor in, right? We see this tongue is completely compressed up here. The airway down here is opened. And so this is a very different picture than what the surgeon has. This is what the surgeon used to plan. This is where they said, okay, this is where I'm going to go target and take out. And now this is what they're actually having in surgery, though they haven't been able to see this before. So what we did was, okay, we want to see how much deformation is there really. We ran a little study and we had 8 patients that were undergoing staging laryngoscopy. What we basically did was the patient was placed under general anesthesia. We took a pre-op scan without having the scope in place, put the scope in place, and then took a CT afterwards to see what type of deformation we actually get. And so what we can do with that, right, is we can segment these different structures out. That means just basically highlight the structures and pull them out. And so in this image that's spinning, we have the skull, we have the mandible, so the bony structures. We have the tongue down here in pink. We have some vasculature, and there's our laryngoscope right in there, right? And so we can see, even at this image here, significant tongue deformation. It's swept to one side. The mandible is opened. The other thing we did in this case was we actually put fiducials on the tongue. So we put these little metal coils on the tongue so that when we deformed it, we could actually track those in space too and get a sense of how much deformation we're seeing in the tongue. We registered this to special planes within our head. And if we start looking at how much motion we actually get in here, we see this is blue is after and gray is before. This is the hyoid and the mandible. Here is the tongue. We see the displacements here. And so we're seeing about 1.3 centimeters displacement on average for all locations. And some of these tongue locations are up to like 4 centimeters in displacement. So these are huge displacements, right? You think about a tumor that might be 2 centimeters in diameter, or your whole space here is 10 centimeters, right? 15 centimeters. We're talking huge deformations here that a surgeon is mentally estimating where that tissue is moving because they don't have those intraoperative images. We also looked at tumors. And so red here is our pre-op tumor. Blue is our intra-op tumor. So blue is after we've put that laryngoscope in place. And so again, very large displacements between these. So on the order of 1 centimeter up to 21 millimeters in deformation. So again, big changes. And then the final thing we looked at was vascular displacement. So these are those critical structures that the surgeon wants to make sure that they don't nick as they're cutting through here, right? And so we have the blue is our intra-op. So this is after it's in place, and the red is our pre-op. And so again, a lot of deformation. The 3D printed laryngoscope and the suspension arm, this is the first time we were able to actually image and quantify some of these changes. And so what do we see? We see lots of changes. I just mentioned all of these displacements. The implications here are, right, these are large displacements, currently require this mental compensation for the surgeon to do. Visual feedback provides some guidance, so a surgeon can look in there and they can see like where the tissue is moved. But some of these submucosal anatomy, so seeing vessels that are underneath the tissue surface, they can't see that, right? And so they don't really know exactly where that vascular is moving. The other thing is all these minimally invasive approaches, right? It used to be that the surgeon opened this up and they were able to feel around. They lose that haptic feedback, right? And so when they could before feel where an artery might be pulsating or where a tumor might be stiff, they no longer have that haptic feedback. And so these are still significant challenges for them. And so again, reminder, we have all these large centimeter size displacements. Margins that they're looking for are 3 to 5 millimeters. So it's a pretty small margin. And they have huge deformations. So So then the other thing we're interested in, not just deformations, but how accurate are surgeons at targeting things, right? So they want to go in there and target the back of that tumor. How accurate are they? So because we have this technology now, we can start looking at how accurate they are. We built a cadaver head holder. We actually have a paper that's called something like Cadaver Head Holder for Transoral Simulations. And it's the weirdest title of a paper that I have. But we did publish something on that. And we took this into CSI. We put some beads inside these cadaver heads, so these targets. And then we put our laryngoscope in here and asked the surgeon to target these beads. And the way we did this was we gave the surgeon a pre-operative image when the laryngoscope wasn't in place. So no deformation. This is what they would see clinically and how they typically practice. Then we gave them an image after the laryngoscope was in place where the deformation was, right? And what we found, pre-operative and intraoperative, so significant differences in target placement. So there was an improved target localization of 21%. When they were given that image with the actual deformed state. They also, task completion time to actually put pins and localize to those pins decreased by 25%. So that was great. So significant improvements if we give them the updated map, right? The challenge, however, is if we look at this column over here, right? This is our intraoperative error. It's still 10 millimeters. So they were still on average putting these pins in about 10 millimeters away. The tip of the pins are about 10 millimeters on average away from the bead locations. Okay. So better by giving them that updated map, they could do better, but we're still targeting that 3 to 5 millimeter kind of margins, right? And so, we said, okay, this looks pretty good. How helpful would this be just using state-of-the-art standard of care guidance system? So we took one of these neurosurgery systems. We used our laryngoscope. We put some fiducials on the patient. We got an intraoperative CT with it all in the deformed state. And then we tried to do kind of intraoperative navigation, and it worked well, right? So this is the surgeon placing in some instrumentation here. We can see our triplanar view up here. We see our cross hatches that are following the targeted instrument. We see our CT updating as we're doing this, right? So now we put the laryngoscope in. We're able to actually do image-guided kind of procedures within transoral surgery. So problems, right, where intraoperative CT is required. We talked about that already. Tumor delineation with CT can sometimes be difficult with CT alone. So a lot of times you want an MR, for instance. Repositioning the scope, right? So oftentimes the surgeon is in there and they're moving things around to get better access to somewhere. All of a sudden then our maps are stale again, right? And so we'd have to re-image, and re-registering the patient takes some time. And then the other thing that the surgeon found was the triplanar view, really not ideal in these procedures. It's very challenging to track where you're going with that triplanar view. And so we thought about, okay, can we do deformation, right? So can we do deformation modeling? Can we think about other intraoperative imaging? Can we track instruments in our scope and use that to kind of build a better model and visualization for the surgeon? So we built this sensor-equipped retractor. We have a bunch of pressure sensors that are on the retractor. And then we embedded some EM tracking. So now we know where that retractor is in space. We have some loading conditions on it. And we can we're seeing here that we're guiding this in the patient. We're seeing some loads on here. And I'm not going to talk about this data today, but one of the things that we're interested in is the amount of anesthesia that's provided for the amount of load that you're given. So there's some evidence that the amount of stress you're putting on the patient, basically how much the load is pressing, can dictate how much anesthesia they're getting. And so we're kind of looking at our data to evaluate if there's an impact of that. But what we're hoping to do then is take this force and location data and use that to drive a deformation model. So what would that look like, right? So we would think about getting some preoperative CT, right? We can segment our CT, find out where our tongue, our tumor is, our vasculature. We have our tracked laryngoscope, so we know where that is in space. We know how it's interacting with the tongue. And so the idea would be can we build a deformation model that tracks where that scope is, and we update the tongue and the soft tissue. So we collaborated with a group at University of British Columbia who had this this multi-body physics model of tongue deformation. We worked with them to augment it for this surgical application. And what we were able to do is, now this is tracking the laryngoscope in real time. And then post-processing right now is this deformation model. And so you can see that the head is moving, the mandible is moving, and we're getting this tongue deformation. So now we're deforming the tongue from our pre-operative image. So the idea would be, okay, can we modify, deform our tongue and provide this type of information to the surgeon instead? So we did some validation studies where we basically put the laryngoscope in, we tracked it in space, we locked it down, we imaged after and before the laryngoscope was in place, and we looked at the deformation profiles. And so if we don't use any deformation modeling, blue is before, pink is before and blue is after. No deformation modeling. We took a preoperative scan and an intraoperative post-op, post-laryngoscopy scan, and we see huge deformations here, right? And so we can do the same thing. We registered it to couple different planes. Our deformation model, however, in 3 of the 4 cases, we see this really nice mapping, right? So this is basically, we updated our preoperative image, and we got this really nice deformed map that now is actually matching our intraoperative state. We had this one case where it didn't match as well, and it ended up that our first case, the EM tracker slipped on the laryngoscope. And so that's why we got this kind of lost registration there. But you can see a significant decrease from these 1637 kind of millimeter errors down to 8 millimeters with this deformation model. So a significant improvement without requiring continuous intraoperative imaging. So for these laryngoscopy procedures, we've developed and validated this CT-compatible laryngoscope and suspension system, quantified deformation. We used this in actually image-guided transoral surgery for the first time. We had this instrumented scope. We developed a soft tissue deformation model. So lots of pieces to get us towards this image-guided surgical framework. Definitely some limitations. So laryngoscopes are only used in a subset of procedures. And then the other thing is the targeting and deformation. So we got down to 8 millimeters. Still not that 3 to 5 millimeters that we're targeting, right? And so we're really trying to get to that value there, right? And so I'm going to transition just a little bit. It's same anatomy, but we're looking now at transoral robotic surgery. Similar thing. We have these metal retractors, metal suspension system. It's robotically controlled. The one difference here is during those endoscopic procedures that I was showing earlier, the surgeon's looking at a 2D view. With the robot, they actually have 2 cameras, so they can get this stereoscopic view. They get a 3D view of the anatomy inside, so it makes a nice, much nicer kind of environment to operate in. But so PhD student Yuan Shi graduated, and she built this really nice 3D printed retractor system now, a little bit more complicated than our laryngoscope. We have this is onyx carbon fiber 3D composite 3D printed retractor blade. And so this is our cantilever blade that's pushing the tongue down. The rest is in nylon. We have a bunch of different knobs here for adjusting it. And we have another suspension frame that we designed here. And so we check this out, and you can see with the metal retractor they have up here, we see, again, artifacts. With this 3D printed one, really nice, crisp images. Our opening distance is the same as the metal retractor. It's around 40 millimeters. We have really good, adequate exposure. We do our MR similarly, and our working volume that the surgeon is actually operating in is equivalent to a metal retractor as well. So great. Now we have this retractor system that seems to be working well. We did some tests to perform looking at the exposure, how well we can maneuver within this retractor space. Surgeon's really happy with this. We implanted a faux tumor in our cadaver, and we're able to resect this nicely. And so the process looks pretty nice here. So now we have this retractor, and we're thinking about, okay, how do we get this into a fully kind of integrated image-guided system? And so Mike Coco did a lot of work at kind of integrating tracking technology, so EM tracker. We have segmentation and a visualization display. We have preoperative imaging. We have coils that are tracked in space. And the idea is to feed this image here into the robotic visualization that the surgeon looks at. And so then we have this Tile Pro format that allows a surgeon to see their vision, what they typically see, and then see some augmented view that we might bring in. So we did this little study where we put beads into the head again, and we asked the surgeon to perform this procedure where we asked them to put these pins, target those beads again. We have an instrument that has a EM tracker on it that interfaces to a robotic instrument. And we had the surgeon go in, and so now Joe is operating robotically here. He has the triplanar view, which we know isn't ideal, but that's what we had at this point. He's putting these beads in, putting these pins in, and you can see over here, it's a little tough, but there's blue and red dots. And blue is I think, ground truth, and red is where the surgeon actually placed it, right? And so when we look at this, using this navigation, so now they're navigating where his instrument is with that pin, intraoperatively, we see target localization errors. Okay, we're getting close here, 3.5 to 5 maybe, right? And so we were bringing that target localization error down closer to that 3 to 5 millimeter range that we got. Remember, you know, we were getting 10 millimeter target localization errors when we just gave them that updated map, right? We didn't navigate, we just gave them the updated map, right? But now we're actually guiding them in place as well, and we're bringing down these target localization errors. So that's great, right? So we're happy with that progress. But can we do better than that? And so the triplanar view, lots of feedback. They don't like it in terms of actually operating, right? So the idea is, can we provide a 3D model that is a better representation of what the anatomy looks like? And so we looked at that. With that model, it also allows us to kind of give them X-ray vision, which is like superhuman, right? So they can actually see this model. We can turn transparency on, and they can start seeing actually below the surface. And so we developed this little throat phantom with some tongue and tonsils, EM tracking. We got a CT of this, and so this is like our pre-op CT. We segment that. We're now tracking our endoscope in space so we can register the objects together, and we're trying to give them this 3D view. So how's this look? So here's Mike operating, actually. So it's Mike Coco operating. And we have this little optical tracker that, here, I think I showed over here, is the optical tracker. We're tracking the camera. And one of the nice things now, so this is what Mike is seeing inside the robotic inside. That's his visual view, right? And right below here, this is the model that we're generating. So that's our CT model. It's segmented. And you can see that as he's moving the endoscope around, the model here is moving around with it, right? So our model is registered to that intraoperative view. And so this is a really nice, way of saying, okay, we're optically matched our model to what the surgeon's visually seeing. And so what we've been doing is these studies where we have beads that are embedded in these silicone phantoms, and you can see we can't see the beads there, right there. We can't see those, right? But in our CT down here, we can see the beads underneath there, right? So we've set transparency on. The surgeon now sees these beads. The other thing we've done is you can see these numeric values down here. So these are kind of like heads-up display. We're actually telling them how far away the needle tip is from the bead and what angle error they are, right? So now we're allowing the surgeon, so before they insert that bead, they can check their angle, their trajectory, they can see where it's going, and then as they start progressing, you can see how close they're getting to the bead. And so this blue thing is actually the pin that's being placed, and the beads you can see there. We've also done this in cadavers, and so this is the same exact thing, but it's within a cadaver model. And so the surgeons are really liking this view a lot better, I'll say that. And so what do we see here? So phantom study, surgeon were blinded to the target, so they didn't see the targets. We compared this with and without navigation. So they had a pre-op image, but they didn't have navigation turned on. And we also looked at different levels of experience. So this is an attending, and then this is residents at different years. And so this is error on the y-axis here. The orange is no navigation, green is with navigation. So significant improvements independent of your skill level, right? So this is a first-year resident, and even they went, improved 50%. It's very interesting also, the first-year resident actually was doing better than the fourth-year resident, huh? Be careful on who you get doing your surgery. But it's good to see that the attending was doing the best, right? So that was, I think Joe was very happy about that outcome. I'll say that. But you can see that even the attending, right? So we gave him navigation. He dropped down to 2.1 target localization error. So we're getting down now below that 3 millimeter target. So that's kind of the ideal place we want to be. So this is really exciting to be in this space in terms of actually doing some image-guided transoral robotic surgery here. A few other things, but just general observation before I jump to them. So, we talked about significant deformation between the pre-op and intraoperative anatomy, right? So greater than a centimeter. So they're doing all of this mental calculation of where things are moving now. The polymer-based retractors really enabling for us to actually quantify the deformation and to make image-guided surgical applications possible in the transoral surgical space and robotic space. Triplanar vision, not great, but the 3D rendering seems to be a lot better. In fact, the surgeons said that, as they were doing these procedures, they kind of stopped looking at the visual feed and were operating on the 3D augmented view that we were giving them, right? And so that's kind of exciting to say that, okay, they really appreciated that extra kind of information at depth that we were able to provide to them. So we have an IRB study coming up to actually do some in vivo validation of the technology. I'll talk a little bit here about overlay-based augmentation we're trying to do, some intraoperative sensors, and then we're also developing some other guidance beacons that we're putting at the margins. And then some other soft tissue applications. How much time? Yeah, okay, good. So towards augmented visualization. So one of the things that's really nice about the robotic procedures, right, is we can get this stereo vision. Right? So we have this 3D view, and if you capture the right and left cameras, you can create a kind of a 3D surface of what the surgeon's looking at, right? And so what we would like to do is to be able to take other sensing technology or that preoperative imaging and actually overlay it directly on their right and left eye. So instead of having these two views that we're looking at, we have a single view that they can basically kind of turn on their augmentation, or they can operate actually on the visual view. And so Mike's been doing some work in terms of capturing this data. So we need high-speed frame grabbers to capture data from both channels synchronously. There's a lot of processing that goes into actually creating the stereo vision and then displaying it on the surgeon's cart. And one of the things we're looking at is a CNN-based disparity mapping. So one of the complex or computationally lengthy processes is to actually create this thing called a disparity map, which looks at the correspondence between two of these images so that you can actually generate this 3D map. And what we're seeing is, typically this could take tens of seconds, and we want real-time imaging. And so, putting this on a GPU with this CNN-based approach, we're getting down to the order of 1.83 seconds or so. So we're getting closer to that kind of real-time updating that's going to enable some of this augmentation. Other things we're doing in terms of that, so last mile sensing. So one of the things we might want to be able to do is to say, okay, here's the margin. Let's really check if there's cancer left behind. And in oral head and neck cancer, these positive margins are a real problem, right? So this is 5-year survival rates. If you have a negative margin versus a positive margin, and you see in all these other cancers, of course you do better if you have negative margins, but in head and neck, the drop is drastic between a positive margin and a negative margin. So we really want to make sure that if we're taking a cancer out, we get as much of it out as possible. And so the other thing my lab does, other than kind of this image guidance, is we do this thing called electrical impedance imaging or sensing, and it just looks at the electrical properties of tissue. To basically, it's a non-invasive, non-ionizing kind of approach to evaluating tissue. And Sophie Lloyd's created this really nice a probe with an active electrode sensing element at the end. And you can see down here, we can take this into the OR. We put this in patients, and we were checking a healthy and a cancer side. We have a clinical study going on right now to evaluate this in terms of evaluating margins. And early data is showing, so blue is healthy, orange is cancer. And so really significant differences between cancer and benign tissues. We've shown it's safe, feasible, effective. I think we've done 74 patients now. Really good AUCs of 0.85, so it's basically showing how accurate the system is. And we're still evaluating this. And so I would just two more things quick. We're looking at this image guided platform software and saying, what else can we apply this to? And so, I'm fortunate to work with a team that's just awarded an ARPA-H grant. So Kim Samko is leading this, and Scott Davis, Keith Paulson, Shia Fan, and Mike Coco are also involved closely with this. And this is looking at prostate. And one of the things with prostate that's a real concern is the neurovascular bundle. So you have these nerves and these blood vessels that surround the prostate. And so we're not looking at cancer per se with this. We're trying to make sure that we don't injure nerves and vascular bundles during these procedures. And so Kim and Scott, and we have a bunch of external collaborators work on optical imaging technologies and contrast agents. And so they're developing some new optical-based approaches to identify these nerves. And kind of what our team has been really focused on is integrating their images into the robotic procedure. And so we're kind of taking a little bit of what we had for our TORS stuff, and we're adding into it, our optical tracker. We're going to bring in intraoperative ultrasound, this multimodal laparoscopic optical probe they're using, some stereo vision, and then augmented reality. And the thing is, our targets are now, they want 1 millimeter localization errors, and they want this in real time, so 10 to 30 frames per second. So pretty hard requirements. This is ARPA-H. They're asking for the world, but we're going to go after it. And so some of the things we're looking at using are just advanced tracking with a bunch of different optical and EM things, intraoperative imaging, and then lots of GPU, multi-threaded computation, and broadcast-capable video hardware to do some of this in real time. As a final thing, so that was looking at nerves. We're also looking at prostate, and we're looking at cancer. And so this is Alaire's work, and this is, a very similar probe. Alaire actually designed the probe that went on to Sophie's probe, and we're doing this intraoperatively for prostate as well. And so this was dropped in an auxiliary port in the prostate, and the surgeon's in here grabbing this and walking around and probing different regions. And so, we have a study that just started this summer with this. And so we're hoping to evaluate this in the context of a surgical margin assessment for prostate cancer. All right. So final message. So, deformation, lack of haptic feedback. We talked about that, especially in these minimally invasive approaches, right? So we want to go this minimally invasive approach because the outcomes in terms of the outcomes and the morbidity associated with them are much better in terms of outcomes, much less in terms of morbidity. 3D printed surgical technology is really enabling for some of these intraoperative imaging paradigms. Integration of a lot of this multimodal instrument tracking, deformation modeling, stereo vision, really can help improve how we deliver surgical therapy to patients. Things that are always, I'm thinking about in the back of my mind, right, are the cost to benefit, right? So these are pretty expensive technologies. We talk about intraoperative imaging. Not everyone has an intraoperative CT scan. And so do we need all of these technologies to achieve clinically? I think that's a thing that we have to be thinking about as we go forward. And then from a technology perspective, it'd be really cool to get to the stage where we're doing autonomous robotic surgery, right? So now we have this imaging, we have these sensors, we put that within feedback loops, right? And so huge regulatory burden there. So FDA is going to be like, hey, what are you doing here? But it'd be a really interesting technology development, and there could be some really nice benefits in terms of removing surgical error and things like that with regards to the precision of the procedure. So I will end. These technologies are very integrated. There's a lot of people working on this. I mentioned some throughout here. Number of Thayer collaborators that I'm actively working with, current graduate students, DHMC colleagues. So in addition to Joe Pedafar, Dave Pastel is a radiologist who's done a lot of work with us. Darcy Kerr is a pathologist who's actively engaged. We have a number of Geisel students, so it's been really fortunate in terms of Geisel students have come through, worked directly with the grad students, the engineering grad students in the lab. The Geisel students are learning MATLAB, they're learning SolidWorks, they're 3D printing. Then they're taking our probes and helping out in the OR. My grad students are going in the OR, learning clinical stuff. And so it's this really nice marriage between the collective efforts there. And I've had a host of undergrads that have helped support a lot of this work over the last number of years. Funding agencies, and of course, all the volunteers that have participated in the research that we're doing. I will end there, and thank you all for listening.